Okay, everyone. I'd like to go ahead and do an introduction of our speaker, and because I would like to make sure that he has enough time to address the issues that you, I know, have been most interested in. And again, I want to thank everybody for their participation. And what we're going and just one other piece of logistics is after this presentation, we have one acknowledgement, and then we'll do a quick break before Dr. Kresley and um, um, Greg Anderson come up here. So I just wanted you to be aware that when we finish this, we'll have a moment so that we can clean up and get going for the afternoon session. But as I mentioned to you, we are very honored today to have Paul Lee, who is the Senior Partner for Strategic HealthCare, Inc. out of Washington, D.C. And today I've asked him to touch on what will healthcare look like in 2020. And the perspective I think that he will bring to the table will be that from what is going on Capitol Hill today. He is based in Washington, and he's the lead. He leads the strategic healthcare activities in the nation capital, serving as a key strategist and advocate on behalf of clients on matters pending in front of U.S. Congress, the Center for Medicaid and Medicare, and other federal agencies. Prior to establishing strategic health care in 1994, Paul was Vice President of Government and Public Affairs with the Ohio Hospital Association, winning accolades for revitalizing the organization's government advocacy program. Paul has served for 8 years with a U.S. Senator as press secretary and later as legislative director. He has been an influential voice on many major health care bills passed by Congress over the past 10 years and has played a major role in developing the Medicare Modernization Act of 2003, and now with the healthcare reform initiatives being undertaken with the Congress and senior Obama administration officials. So please give a warm Pennsylvania welcome to our Washington colleague, Paul Lee.
Thank you very much. Can everybody hear me okay? I'll try to walk around a little bit because this side of the room is so ignored right now, and I appreciate that. I do thank you very much. I used to start my presentation out with some kind of a funny story, and then I just say I'm from Washington, D.C., and that seems to do it for most people. And in fact, if I was going to tell you if my presentation was really about what's going on Capitol Hill, I'd be done in 3 words and then I'd leave, little to nothing. And so I'm not going to spend a lot of time on what's going on Capitol Hill. I will talk about it just a little bit because it is relevant at some level. It's relevant in terms of the things that are going on. So there are 3 primary areas that I'm going to cover while you're eating lunch. And Chris said that my goal was to make sure you left with indigestion. And I'm going to do my best to make sure that happens. So I'm going to talk about what's going on from a federal perspective. I'm going to talk about the markets, because there's a lot going on in markets around the country, and then where healthcare is going over the next 8 to 10 years. Now, I don't expect you to agree with everything that I say, but I think you'll see when you look at the data, when you look at the information, that it's pretty compelling in terms of where healthcare could be going. The first few slides here, and looking at where the federal government is focused, I'm going to focus on several aspects, the large ticket items. The SGR fix, and I'll talk about what SGR means for those of you who don't know, budget sequestration and other provider cuts, because we think that they are coming. So SGR, the sustainable growth rate. This is the formula that Congress created back in the late 1990s with the idea that when they saw the cost curve in terms of how physicians are being paid by Medicare, the curve was going to be unsustainable. So they created a formula to try to rein in healthcare spending for physicians specifically. The way the formula works, though, is it's the law of unintended consequences. Here we are 15 years or so later from when that particular formula was created, and as you can see on the slide, that there was almost a 27.5% cut averted on January 1 of this year. Congress acted to avert a 27. How many physicians are in in the audience here? Let me see a show of hands. How many physicians? A few docs in here. So physicians have a deal, those who take Medicare patients, physicians have a deal with the federal government, essentially. They're in a business partnership with the federal government. And as a partner, the federal government hasn't turned out to be a very good partner overall, if you're a physician. Because every year now, maybe multiple times during the year, this formula comes into play, and Congress is talking about, well, there's going to be another huge cut if Congress doesn't act. We're facing that again. So this was an $18 billion fix that Congress did at the end of last year to make sure that we could take this SGR formula all the way through the end of 2012. That was the fix. In fact, last year they made 3 or 4 different fixes to get to the final, to make sure that physicians were not actually, or did not actually receive a pay cut during 2011. And so throughout 2012, one fix for 2012. 1-year fix for 2012. Now, on January 1, we're looking at another problem. This time, the way the formula works, the cut is going to be about 34%. 34%, unless Congress acts to stop that cut. There'll be a 34%, and there's a growing number in Congress on both sides of the aisle who are saying, well, you know what, doctors make an awful lot of money. Maybe we should just let this cut go through, see what happens. A permanent fix to the SGR, as you can see, is $320 billion. And even in Washington, $320 billion is still a lot of money. I know it doesn't seem like it, but it's still a lot of money. So nobody wants to fix or provide a permanent fix to the SGR because the cost is still very substantial. So what's the likely action? Probably another short-term fix. How long? We don't know. What will they have to cut to pay for it? We don't know that either. However, last year, for the first time, since the formula was created in the late 90s, for the first time, they cut hospital payments to hospitals under Medicare, to pay for the physician SGR fix. That was the first time that's happened. Now, of course, things have changed a little bit, as we'll talk a little bit later here. Things have changed a little bit, and now, you know, a lot of docs are employed by hospitals. So hospitals are now engaged in this SGR debate like never before. Because if you're cutting the physician payment rate, that affects the hospitals, what the hospitals get out of this. So it all is starting to work together. None of it is very good. And again, this cut takes effect on January 1. So we're facing a number of huge changes. So the next big problem that we have, unfortunately, is on January 1. I know you're starting to see a pattern here. January 1, sequestration. So in a grand deal last year between the Democrats and the Republicans, the White House and the Congress, essentially they decided we're going to cut about $1.2 trillion out of the budget over the next 10 years. We have a budget crisis in America, deficit problem in America. We've got to fix this thing. $1.2 trillion over 10. Split 50-50 between defense and all other spending. Medicaid is exempt. There are a few other smaller programs that are also exempt. Medicare is not exempt. So essentially what will happen on January 1 is that there will be a 2% across-the-board cut in Medicare. Now, the Secretary of Health and Human Services has a discretion up to about 5% within the HHS budget to cut programs how she sees fit. But overall, the overall Medicare impact is about 2%. So we don't know exactly how this will play out. Most CFOs in most hospital organizations today have already booked or cooked this into the books for next year, anticipating what? That Congress won't be able to fix this. Congress won't be able to fix this. Not before January 1. And I don't think there's anybody who thinks otherwise at this point. Now, it's not entirely true that there are a lot of members of Congress who are hopeful that things are going to happen to try to avert this, because the Republicans who control the House of Representatives, remember the Republicans have the House, the Democrats have the Senate, of course there's a Democrat in the White House. So the Republicans in the House are like, oh my goodness, this is going to decimate defense. We can't do this. So they've been trying to come up with a way to fix the sequestration law so that defense is not hurt as much as it is under current law. So what did they do? Last week they passed a sequestration fix bill. And what did they do? They put more money into defense, and where did they take it from? You. They took it from HealthCare, mostly. And as you can see, I just listed about 6 or 7 items here, and as you can see, the Republicans don't appear to be big fans of health exchanges. They would literally wipe out health exchange subsidy money. Health exchanges would not exist if the Republicans had their way, at least not in their current form. And I should say at this point that I'm going to do my best to be very bipartisan or nonpartisan in my comments, because it's very easy to jab one party or the other, and I will do both. So if you're starting to think, well, he must be a Democrat, listen to him talk, or he must be a Republican, look at that. I'm not going to tell you until the very end, and I'll ask for a show of hands to see what you think I might be. But I think the point is that it doesn't really matter which party. Neither of them have been able, neither party, as you know, have been able to work well together in the sandbox, as they say, at least over the last couple of years. Now we have a big election coming, and it's going to be close, so they say. So what does this really mean? Well, there's one more thing that's going to happen before that election of some significant consequence for HealthCare. Aren't they a good-looking group? Now if they could only sing. So yes, the Supreme Court's going to make a decision, probably announce it in June, although we're hearing it could be July, but I think June is the more likely date based on everything we've heard to date, as to the constitutionality of the Affordable Care Act. Now, it's interesting to hear previous speakers talk about what's going on related to, health IT, for example, your areas of expertise, because there's a lot that's going on in the Affordable Care Act associated with this. Now, the High-Tech Act was separate from the Affordable Care Act, so that's going forward no matter what. However, there are a lot of things in the Affordable Care Act that we're not really sure what's going to happen. And here's what I mean by that. The Supremes can do one of 3 things, basically. They can throw out the entire law, they can keep the entire law, say it's all constitutional, or they can say, well, there are portions of this, particularly the individual mandate, which is really the focal point of a lot of the discussion, legal discussion that's going on within the court. They can say that is unconstitutional and maybe a few things going along with it. So they can do one of those 3 things. Worst case scenario for those of you in healthcare is the scenario that says the Supreme Court is going to say the entire law is unconstitutional. Why do I say that it's of significant consequence? Because a lot of that law has already been implemented. More to be implemented. They've already spent billions of dollars through CMMI and other agencies within HHS, and in fact other agencies as well. Spent billions of dollars, planning to spend billions of dollars. Many of you are counting on many of those billions of dollars in some way, shape, or form. What happens if the court throws everything out, says it's unconstitutional? Nobody knows. Nobody knows. So you see some of the media reports where the Republicans are saying to the White House, what are you going to do? What's your contingency plan if the whole thing is thrown out? What are you going to do? And of course, the White House says, we don't know. We think they're not going to throw it out. And now the Republicans in the House of Representatives are being needled a little bit by the media and Democrats saying, what's your alternative? You've been saying we're going to repeal Obamacare, we're going to repeal that law, and we're going to replace it with something else. What are you going to do? And the Republicans are divided about what it is they might want to do to replace Obamacare. Doesn't that give you a lot of confidence? Because part of your job is looking ahead, planning ahead. How can you plan? How do you know what to do if a lot of these things are literally hanging in the balance? How do you know? How do you plan? How do you deal with that? And I know that a lot of folks, not just in this room, but across the country, are really concerned about thinking how this is going to play out over the next several months. So June is this decision. Then on January 1, I've already mentioned the SGR, we've got sequestration, and I didn't put it up here because It really isn't a healthcare thing, but it kind of is. There are two other items. One that also happens on January 1. The so-called Bush tax cuts expire. You've heard a lot about that in the news. Okay? It will raise everybody's taxes. That's getting you even more excited, I know. So that happens on January 1 as well. So you got the SGR, sequestration, Bush tax cuts, and then around the same time period, the Treasury Department thinks that could be early January, maybe February 1, the debt ceiling needs to be raised again. Wow. Are you excited or what? So at the end of the year, so remember the debt ceiling, that's where the last time we had to raise the debt ceiling, that's where the Republicans said, if you don't agree to something close to our plan, which means significant cuts, which they made, that was the grand bargain to get us the sequestration, remember, then we're going to let the debt ceiling just kind of not be renewed, and the country will default on its debt. So they played a game of chicken. Now, of course, that one is going to be a little bit more controlled by perhaps what happens by the election, because Treasury seems to think they can wait until January after the election, maybe February 1, before they have to raise a debt ceiling again. But all of that happens. Everything I just mentioned happens in the next 5 or 6 months. It's going to be an exciting time. Then, of course, we have an election. Oh, did I mention that? We have an election in November, and the entire government is hanging in the balance. So most people think the House of Representatives will stay Republican because the Republicans have so many seats right now, but it will be a narrower margin. The Senate, I used to say that it really mattered who was in the majority and who was in the minority in the Senate. It doesn't really matter anymore because you have to have 60 votes to do anything important in the United States Senate because of the way the filibuster law is being interpreted in modern times. Nobody's going to have 60 votes. So whether it's the Republicans or the Democrats who are in control of the Senate, doesn't seem to matter. And then who knows who will be president. And all of that happens in November. This is an exciting time, isn't it? So what's driving the debate in healthcare in Washington? That blue line is driving the debate. I don't care if you're a liberal, conservative, moderate, I don't care what your political persuasion is in Washington. That line, that blue line, is driving the debate for everybody. Everybody agrees we have to do something about that line. Everything else seems to be, relatively speaking, stable. Healthcare costs are not. What do we do about it? How do we get healthcare costs under control? That's what's driving the debate. It's really very simple. Medicare is going to run out of money. Social Security is going to run out of money, around 2025, 27, something like that. Both programs are running out of money about the same time period. So that's driving the debate. They're trying to figure out how to fix it. Everybody has good ideas. Compromise is a hard thing to do in Washington these days, as you well know. But the debate, the fundamentals of the debate are pretty much the same. Everybody agrees, generally speaking, with the fundamentals of the economics. It's just how to fix it. So what we're going to see probably next year is some kind of significant Medicare transformational initiative. So these two guys, Paul Ryan, who runs the Budget Committee from Wisconsin on the House side, a Republican, Ron Wyden, a liberal Democrat from Oregon, introduced legislation a few months ago, first time a Republican and a Democrat of some significance. Wyden is well respected on health care issues in the Congress. They introduced legislation that essentially would transform Medicare as we know it. Okay, Medicare today is a defined benefit plan, which means you reach a certain age, here are all the benefits you get. You might have to have some kind of supplemental insurance coverage as well, but here are all the benefits that you get. They want to change it from a defined benefit plan to a defined contribution plan. And what that means basically is that, at least according to the actuaries who did the first analysis on this, was they're going to give everybody who's eligible $8,000 a year. And they're going to go out and buy their own Medicare insurance. Maybe they're going to do it through an exchange that could be created. Maybe not. But then it's a defined contribution. The government's going to give you $8,000, and then this set of benefits you'll be eligible for. Now, those aren't the only two guys. These two guys, both senators, both Republicans, both conservative Republicans, well, I don't know if there's anything other than a conservative Republican anymore, but Coburn and Burr introduced legislation shortly after that other bill was introduced to get the private sector much more engaged in how Medicare will be transformed, even more so. And then essentially the fundamentals are this for both pieces of legislation. Now, by now, there have been a number of bills introduced, just within the last month or two, a number of bills introduced in the House and Senate dealing with Medicare transformation, which tells you, even though it's not going to happen this year, way too volatile an issue in an election year, next year is going to be a big year for Medicare transformation. And depending on your political persuasion and depending on who's elected, you're going to like what they're going to do or you're not going to like what they're going to do. Either way, it's going to be significant change. So if you're 55 or older when this becomes law, basically you can keep Medicare the way you know it today. I don't know, some of you are going, phew. If you're not 55, there's changes coming. You get into that defined contribution plan mode, more than likely. That's where the legislation is headed. In fact, those who are looking at this problem on the left and the right are saying, you know what, maybe we can't have a defined benefit plan anymore the way we've had since Medicare was created in 1965. Maybe we need something that's going to allow us to rein in those costs. Now, as you can see, the ease by which the government then, if you had a defined contribution, 8,000, 9,000, 10,000, the CFOs I talked to in hospital systems are hoping that it's like 10 or 11,000 to start. But see how easy it would be to ratchet that down. Okay, well, gee, Medicare is growing faster than what we thought because of demographics. We're going to take that 8,000, make it 7,500. Very easy for the government to do something like that. Maybe not so easy, but still a lot easier than changing Medicare today the way it is today. So you're going to see some significant transformation. More than likely, if you're rich, you're going to pay more and get less. If you're poor, you're going to pay less and get more. And again, depending on what the final legislation looks like, those will be determined later. So all this is going on mostly within the government. What's going on within the markets? I'm going to touch on several issues here. Health systems, insurers, and physicians. Significant players in the market, in the healthcare market today, for a variety of reasons. This is a great chart. This is mergers and acquisitions activity for hospitals in the United States over the last 10 years. The line on the right-hand side, the one where you see the red going up, that was proposed. That hadn't happened yet, but it did in the end. It was actually a little bit above 95 in 2011. 95 deals, merger deals, acquisition deals between hospitals. As you can see, the busiest year for that in the last 10 years. But when you add all of it up, you can see that there's a lot of merger activity going on. This is not a surprise to you. It goes on in Pennsylvania. It goes on everywhere across the country, with no exception in any state. It's happening at a very rapid pace, a very rapid pace. So who owns these things? Well, before I get into who owns these things, let me talk about the government. The government's role in this. The Innovation Center is also encouraging consolidation of health systems, essentially, of hospitals and other organizations, whether it's by the creation of ACOs, MSSPs, Medicare Shared Savings Program that they've got going on with Pioneer ACO program and the like, bundled payment initiatives, all of it forcing integration, clinical integration. Clinical integration, as you think about your markets, clinical integration really force you to stop and think, well, we need to have a little bit more market share, we need to do more of this, more of that, more meaning in the way it's working out, more consolidation. So the government has programs, is pushing programs through the Affordable Care Act and other means, which is literally getting folks to think, well, maybe bigger is better. Maybe we need to be thinking completely differently than what we have done in the past. And that's not just me saying it, that's what's going on in the market today. Look at the numbers. Now, in terms of who owns these things, well, I don't know. You used to think, well, all these big systems are going to be owned by, hospital people, grew up in the hospital world or whatever. And then that may not be the case at all. Maybe it's another entity, which you'll see in just a minute. And when you look at this, this was a poll that was done of healthcare leaders around the country at the end of last year. And as you can see, the majority of healthcare leaders say that they are actively engaged in discussions about consolidation, mergers. And that isn't just with other hospitals, of course. They're also talking about physician acquisition and the acquisition of other entities in the healthcare continuum. So it's not simply we're going to merge with other hospitals, although those are the big ticket items. but literally across the board. They're thinking about how do we acquire, how do we do everything that we need to do, and literally control utilization across the board for all services that are provided in our community. How do we do that? They do it through consolidation. Who owns it? Well, so you have right here in this state, maybe it's the insurance industry that owns half of the future healthcare systems in the United States. They've got all the cash. Maybe that's what happens. Maybe it isn't just you know, the folks who grew up in the hospital world per se that own these things. And I'm not sure it really matters in the end who owns these entities, but these entities are huge. And of course, you know, Highmark and other insurers have a lot of money. What are they going to do with all their money? Well, they can consolidate, and that's what they're doing. The insurers are consolidating as well. This is a great quote from Aetna CFO who said, "I think you'll see the larger plans that have significant capital be the consolidators of the small and regional plans." And then you have a list of small and regional plans on the left-hand side there, what their stock price was and the likely targets. This happened the day after Wellspring was taken over by Aetna. So you have a huge initiative going on the insurance side of the ledger. Mergers and acquisitions as well. And so the markets are consolidating significantly across the country. That's happening also, like hospitals, the insurance consolidation is happening at a very rapid pace as well. So now you're starting to get a picture of what the market is looking like. This is probably the most compelling piece of information, I think, in the 20, 25 years I've been doing healthcare. And that is what this chart basically shows, that blue line in the middle there going down, those are independent physicians. So independent docs, there's only about a third of them left. Everybody else is owned by somebody else. I never thought I'd see that line go down. When I got into this, like many of you 20 years ago, physicians over my dead body, will I ever join, you know, that hospital or that organization or this or whatever over my dead body? Well, there's apparently a lot of dead physician bodies out there because it's happening at a very fast rate. Okay? So, and it's not just hospitals, you know, that are owning them, but it's predominantly hospitals. Predominantly hospitals. So this trend also, basically, as you look at the market with what's going on with the consolidation with hospitals, with insurance companies, with physicians, you know, joining in this process, now you start getting a clearer picture. So one of the things that's important to look at, which I try to do here in a couple of slides, is, you know, what is driving physician employment? There are 8 items, 8 reasons why physicians join networks that I put up here for you to take a look at. There may be more than these: declining incomes, demographics, shortages. Hey, it's okay to do this now. It didn't used to be, but it's okay now. Maybe there are better ways to do this, and maybe by being part of a system as opposed to outside of a system, I can make a difference, whatever it is. A lot of reasons now why physicians are deciding to become employed. It's very interesting to take a look at what our future physicians are saying on these issues as well, because, you know, if you're looking ahead, if you're trying to look ahead 10 years, you got to look at where the, you know, back in the pipeline over here to see what people are thinking, those who are getting trained. This is a survey that's done every year, third-year residents. I love this survey because it's just hard to believe that these kids are thinking this. 29% said that they, if they had to do it all over again, they would do something different. They wouldn't become a physician. A third of them saying that. And of course, mom and dad are saying, over our dead body, are you going to change your vocation? You know, so 32% would rather be employed by a hospital than any other option. Only 1% said solo practice. So what does that tell you? My daughter-in-law just started medical school at Ohio State, and I was talking to her about some of these issues a couple of months ago. You know, talk to any student today who's going into medical school or in medical school today, and I was telling her about all these difficulties and what I'm hearing from docs who've been around for a long time and the issues they're confronting. And you know, she said, I don't care about any of that. All I care about is taking care of people and making a couple $100,000 a year. At least she was honest, you know. So 48% said they're unprepared to handle the business side of medicine. I know a lot of you think that number's low. 9% said they are very prepared to deal with it. 56% said they received no formal instruction during their medical training regarding medical business issues such as contracts, compensation arrangements, and other business matters. So, you know, when they're facing graduation, essentially going into residency and literally taking a job or doing something, you know, employment looks pretty good. And of course, geographic location, personal time, and lifestyle, they're most important issues about making decisions about where to land. This probably doesn't surprise most of you. Finally, 72% expect to make $176,000 or more in their first practice. And of course, they're straddled with thousands of dollars of debt. Hundreds of thousands of dollars of debt. Unless that hospital system pays for that kind of thing. If we can, you know, if I get a job over here, then I don't have to worry about that. And that's why they're thinking about those kinds of things. So, what does this mean for the future? I'm going to give you some predictions here. Health insurers are gone by 2020, gone as we know them. The quote up here, you probably can't read it. By 2020, this is a quote, by 2020, the American health insurance industry will be extinct. Insurance companies will be replaced by accountable care organizations. Zeke Emanuel, who's one of the president's advisors, longtime advisor on healthcare, made that quote in the New York Times. A few months ago, wrote a great article on this, looking ahead. Well, you know, the idea is if you're this big hospital system and you own everything, then essentially you're assuming all the risk anyway. All the risk is yours. Why do you need an insurance company to carry that risk? You don't. Now, that doesn't mean insurance companies are going to go away. Perhaps they're going to run all the back office functions for these big conglomerates. Perhaps. You probably make more money doing that, you know, than what they do today. So if the consolidation trend continues, you're going to see between 300 and 500 health systems in the United States by 2025. 300 to 500. Okay, so there's 5,500 hospitals in the United States today. 5,500 hospitals in the United States. In the end, you're going to see 300 to 500 systems. These systems will own everything. Everything. Acute, post-acute, they will own everything. Why? Because that's the only way that they're going to be able to get their arms around these massive cost issues, like community health issues like diabetes or obesity, you know, smoking. All these things that are driving costs in America today, dramatically driving costs, are community issues. And if you can't control the entire network that you have, if you can't control it, then you can't control your costs. Or let's put it this way, there are other entities at play that have decision-making authority in the area of costs, and you don't control it. But the way the government's moving, as you well know, they're going to start holding everybody accountable. 30 days post-acute discharge, you know, if you get a readmit within 30 days, you're going to get dinged, and other penalties that come into play on quality and on infections. And the community is going to be a much larger, and I could do a whole presentation on the community role of the future of healthcare, but I'm just trying to give you the picture that in the end, if we don't have this kind of consolidation, how do you get at the issue, the fundamental issues of cost? You really don't. You really can't. Right now, it's all about market share, driving market share and whatnot. In the very near future, it's going to be, this is how we get our arms around the entire cost issues associated with healthcare in America today. So, you know, 50% of all inpatient admissions, hospital admissions, are obesity related. How do you deal with that? How in the world do you deal with that as a community? And you don't want to pay any more in healthcare for healthcare. The government doesn't want to pay any more. Private insurers don't want to pay any more. What do you do? And that's what these folks are starting to think about is, you know, if we're going to be successful at trying to get our arms around this, we're going to have to consolidate. So 300 to 500 systems. Health systems will be very regulated, though, by the government. So there'll be competition between these large mega systems, at least theoretically. And then physician oversupply. What? I thought we had a physician shortage. You know, there are more physicians in medical school today than at any other time in American history. In 2011, medical school enrollment was at an all-time high. You know what? It's going to be higher in 2012. You know, there are 20 new medical schools coming online within the next 2 or 3 years across the United States. More people want to go into medicine than ever before in our nation's history. And of course, they keep hearing that we've got these incredible physician shortages, across the country, depending on where you live. Be a senior today and move into a new community and try to find a doc that'll take a Medicare patient. It's tough, okay? But in 10 years, why would there be an oversupply? Well, if you only have 300 to 500 health systems and they control everything and they own everything, and by they, I don't mean the hospitals. Maybe it's, Highmark that owns everything. I don't know. But they own everything. If they can control 100% of utilization virtually in every community where they exist, then they say, well, in our community is, 250,000 people. That means we need 8 orthopods in our community. Uh-oh. I'm number 9. What am I going to do? What do you mean you're not going to hire me? Well, we only need 8. That's what our numbers show. And when you go through the lists of, how many specialists there are in all these different areas, the only place where there might be a shortage in the future is primary care and related specialties. But all the others, there's an oversupply. So we might be facing, in a matter of 10 years, literally a physician oversupply. So the large salaries that physicians are expecting coming out of school today may not be there in the future. Certainly the economics of medicine is going to change dramatically over the next 10 years as a lot of these market changes start happening more significantly than even they are today. Well, come on. Let's come on. The sun will come up tomorrow is what it says right down here. The sun. You're all supposed to break into song at this point, and do the little Orphan Annie thing for me here. In 1982-83, when DRGs were being created in Washington as a way to get your arms around healthcare costs, the government to get its arms around healthcare costs. Remember before '82. Okay, those of you who were in healthcare before '82, what a wonderful time that was. Cost-based reimbursement. Ah, those were the days, How much did you get paid? Well, whatever it cost. So what are you going to do? Well, I'm going to spend more because it's a great deal. So Congress said, no, we're not going to do that anymore. We're going to change everything, '82, '83. I was working for a senator at the time on the Hill, and we had a legion of hospital administrators coming through the office. Oh, it's the end of healthcare as we know it. This is it. If DRGs go through, it will be the end of life as we know it. And of course, DRGs happened. And in fact, over the next 4 years, hospitals made more money from Medicare than they'd ever made before because the government hadn't quite figured out how to tweak it well enough yet, and they didn't want to pull the plug on it. And so everybody was getting paid more money. So if you were in finance back then, it was a great time to be around. Okay, the point being that we got through that time period. We made it. And the future, if I've ruined your lunch, I'm not sorry. But, the future is just that. You don't know exactly what's going to happen. You guys are in the information exchange business. You all are I like to say, you all are in the business of kind of like what I am in lobbying in Washington. You're the oil in the engine. The engine doesn't run without information. And so, you're the new, we represent dozens of health systems across the country on a variety of things, and I always tell the CIO when I'm in a meeting, especially when the CEO's in the room as well, I say, you're the new black hole of healthcare. There isn't enough money to pour in what you need, on the CIO side, because that's where the future really is. You need a lot more information and organizations like this and you all coming together and trying to sort a lot of these things out, that's where it's happening. And I can't tell you how many meetings I'm in Washington, whether it's with an agency or on Capitol Hill or whatever, every week saying, well, when the information systems come online or when we actually are able to get this kind of information, we're going to be able to do X, Y, Z. That's all I hear about day in and day out. So you're right now, you're in the sweet spot of healthcare. It's not the medicine side, it's the information side, which is really the sweet spot. This is where most of the money is being spent today in terms of any kind of discretionary dollars going to health IT. But eventually, if the health IT thing works, you're going to be the reason why the scenario that I just painted is going to happen. You're going to be the reason why consolidation works. Consolidation doesn't work without good information. So congratulations. You're the reason why that scenario that I painted is actually going to happen, probably more than any other reason. As government continues to cut back on spending, private insurance wants to find different ways to, to spend money rather than on health care. You're going to be the reason why all that comes about, and I think it's a great thing. So with that, I'm going to stop and see if there's any questions from the group.
Just to screw up the betting pool in the back, I'm going to ask the question this time for the two of us. You know who you are back there. One cost driver you didn't mention that I'm interested in your opinion about for the next year or two is the Medicaid, Medicare reimbursement reconciliation that's supposed to be coming. So do you think they're going to solve that by letting Medicare revert to Medicaid rates, or do you think they're really going to add more costs by making Medicaid truly, I mean, where do you think that stands right now in terms of Medicaid being forced to rise to the Medicare reimbursements?
If the Affordable Care Act is deemed unconstitutional, none of that matters, number one. Number two, if that doesn't happen, then, assuming that it doesn't happen, then as you're probably aware, all the folks who are going to come online to get health insurance who are presently not insured in the United States, most of them are going to get Medicaid. Medicaid's going to be paid at the Medicare rate for 4 years. And then, of course, at the end of 4 years, or maybe starting at year 2, 2.5, the states are going to be clamoring in Washington, you can't let this end at the end of 4 years. So the push is going to be obviously to keep the rates higher. There's no question about it, because if states have to shoulder all those costs at the end of that 4-year time period, depending on the economy, of course, who knows, but it would be a very difficult probability for many states to be able to do that. I'm going to put my money on the rates staying higher rather than going back, reverting to a lower rate, at least for a period of time, until all of this is sorted out and we have a single-payer government program for everybody. Yes?
So just as a segue to that, on your companies that were primed for takeover, most of those companies were Medicaid managed care companies, and that is, of course, tied to the HCA, which is before the Supreme Court. So that could change, correct?
That is correct. So the value of a Medicaid company or if the Affordable Care Act is deemed unconstitutional, Medicaid, it's a pretty good deal for them right now. I mean, the value of their companies are actually a little higher these days, anticipating that they're going to be, key in the reform effort over the next 5 years. I think you're right. I don't think that minimizes, though, the interest of the larger insurers to consolidate the industry. The list was mostly Medicaid, but I think you're absolutely right. Those Medicaid players may even change. In fact, they'll sell for a lot less than their posted price, on that day. Other questions? Yes, sir.
Hi. I have a question about health information exchange. As you probably know, there's generally 2 flavors of HIE, the kind that occurs within a single institution, UPMC or maybe a Highmark or some other health system, and then that which occurs across organizations. And if the concept of consolidation continues and it ends up at 300 to 500 health systems and however many in Pennsylvania, what would you guess would be the role of that public or cross-organizational HIE in the future?
I think that what we're creating with information technology right now is a transformation time. We're in a transformation time period. Let's put it that way. And HIEs, you remember, there have been a few successful community HIEs around the country, sustainable, self-sustaining HIEs. Not a lot. I think it's transformational. So in the end, depending on what the government decides to do, obviously a large mega system is going to have to be able to share their information across multiple platforms. No question about that. But whether or not you need a public entity, I don't know. I think it's too early to tell you the truth. I think you can make an argument for either. Maybe the government comes in. The debate that's going on right now, if insurance exchanges actually survive whatever happens with the Affordable Care Act with the Supreme Court, you've got a debate going on whether or not it should be a federally run exchange or whether or not the state should run the exchange. And what's happening in the conservative and the red states, so to speak, in those conservative red states, they're saying, no, we don't want to do this ourselves because that would mean that we're agreeing with Obamacare. So we want the feds to come in and run it. I don't get that. But that's what's going on there. And in the blue states, they're creating their own, for the most part, moving forward with that. I don't know how that's going to play out in the end. Your guess is as good as mine. Yes?
Hi, Paul. One thing I'd like you to drill down on. I thought it was very dramatic when you said, okay, maximum 500 health systems across the country. And they'd be very competitive. I would think that actually the threat would be that they're going to be a little monopolistic in their dominant territories and maybe a little bit at the margins. So where's the competitive feature come in this, I've got all the risk and I'm controlling all the patients and I've got all the data now?
Good question. When I think of one of my favorite cities, Pittsburgh, I think of two systems in the end. They're going to be competing. I think in most major metro areas, you're going to have more than one system. They will compete. When you get outside the major metro areas, it gets a little dicey in terms of competition. But you know what? That's already the way it is. How many communities have sole community, hospitals? Essentially, there's no competition. One of those systems will own that sole community hospital, but that isn't going to change the fact that there's only one hospital in the community. I think where most of the competition is going to happen, though, will be in the major metro areas around the country, where today, in every major metro area, you have more than one system. Every single major metro area has more than one system today. That's where I think the competition actually plays out. Now, the FTC very recently, as you're probably aware, you had the situation in Toledo, Ohio with ProMedica. You had the situation in Rockford, Illinois with OSF Health System. Both systems tried to acquire a hospital. The FTC stepped in, and in the OSF situation in Illinois, they said, okay, we'll back off. In the Ohio situation, they're going, if they have to go to the Supreme Court, they're going to go to the Supreme Court. But the point being that the FTC has stepped in when, so you have this dynamic going on within the government today where most of the government is pushing consolidation. And then this part of the government, FTC, DOJ, Department of Justice, are saying, now we're going to monitor this. And if we see some, anti-competitive behavior, we're going to step in. They step in very rarely today. So you do have this dynamic going on, and the government, I don't think, has a very clear plan itself about what the future looks like. So they're kind of dancing with everybody else right now, but you see where the market is going. Other questions? Yes.
Good afternoon, Paul. In one of your earlier slides, I saw that there was a significant funding reduction for health exchanges. And then later on, and correct me if I'm wrong, I thought I heard you say that the government, through the transformation, especially for those 55 and younger, that they would be provided an $8,000 stipend or about that, and the intent would be for those people to go to health exchanges. Doesn't that seem counterintuitive? And does that matter with the rise of ACOs?
The House of Representatives was looking for money to put into the defense budget. And I think they thought that the easiest place to cut that would result in the fewest amount of objections was the information exchange subsidies, which are tens of billions of dollars. So I don't think that there was any thoughtful thinking about what the future is going to look like. They were also hearing from a lot of Republican governors who were saying, this is awful, this is terrible, we don't want this. And so I think that was more of a political response. In the Medicare Transformation piece that happens, at least in both bills, and more the two bills that I talked about, and it's only conceptual, they would have the federal government create an exchange for Medicare. How it works and the details of that are unknown at this point. How it's funded is unknown at this point. We don't know. So I think that it's just typical politics. People aren't talking to each other, and they're looking for money where they can find it these days, and that's really the result of the first issue on the exchange. Did I answer your question there? And ACOs, I don't know, when you have ACOs, that changes the mix. When you have these mega entities, not the ACOs, but these mega entities that I'm talking about, that changes the mix entirely on health information. I don't know how that's going to play out. Yes?
You may have answered this in your previous merger and acquisition slide, but in Pennsylvania, we're seeing an increasing number of not-for-profit hospitals being acquired by for-profit chains. Do you see that trend continuing, and then what impact is that going to have on the healthcare issues that you've pointed out?
You know, I used to be a really strong advocate of not-for-profit only, you know, ruling the day, so to speak. And my opinion has evolved on that, where I'm not sure there's a lot of difference between for and not-for-profit. Now, I can argue that there are differences, and I can give specific examples of how these differences affect care in a community. But when you're talking about control and where the future is headed, and the reason I'm saying this is because you have the 5,500 hospitals, about 750 hospitals are for-profit out of that 5,500. So they're in the minority. They're about 13%, 14% of the total there. Congress is, next year, one of the things I didn't mention, because there's just not enough time, Congress next year is looking at, I don't care who the president is or the Congress, but they're looking at massive tax reform. And in the American Hospital Association had a call yesterday in which they talked about the fact that there will be hearings starting next year on tax-exempt status. And hospitals and universities are right in the crosshairs on this. And so, you know, I've had a lot of hospital executives tell me, you know what, I'm this close to just saying, you know, forget it all. I'm going to be a for-profit enterprise, not have to deal with all the garbage I have to deal with the IRS, the 990s, and all the other associated community benefit crap that I have to do, and I'm just going to be for-profit and go out there and live life large. Now, I think that's a frustrated moment. Who wants to pay taxes if you don't have to? Up to a point. But I think that the debate is enjoined at this point, and when you talk about meaningful tax reform, you're going to have to put not-for-profit status on the table. And it's going to be a tough call. You see what the IRS is doing right now on this. Because of the Affordable Care Act in particular, the community benefit requirement for hospitals is substantial today. A new Schedule H, you go onto the, you know, just for fun, go to the IRS website, just for fun, and look up draft Schedule H on the Form 990, just for fun. And look at what they're doing in terms of what the reporting requirements are likely to be for a not-for-profit hospital enterprise. It's substantial. And the need to prove a lot of stuff that you don't have to prove today is also substantial. In other words, what really constitutes community benefit. So my hospital system spends $20 million on community benefit this year, and we announce it to the public, okay? Did you get anything for your money? Did you improve health outcomes? You don't have to prove any of that today. The future says you're going to have to do that. Did I answer your question?
And also, actually, local communities putting a lot of pressure on not-for-profit hospitals to pay the tax anyway or pay something.
Good. You know, there's a lot of governmental pressure in particular on not-for-profits to pay taxes. In Illinois, the state of Illinois has a plan on the table right now that would require all hospitals to pay taxes to fund Medicaid. We represent a number of systems there. I think it's going to pass. That would be a huge, and Illinois was the case where they had the property tax issue with Provena a couple of years ago, where the court said, medical office building, you're going to have to pay tax. You're not a hospital, you're a medical office building. Uh-oh. You know, so things are changing fast in this regard. Over the next couple of years, I think that question on tax-exempt status is a huge issue that's going to be debated, and I don't know what the outcome is going to be, except the government wants more money, so you know what that might mean. Yes.
So does that review apply to payers also, as well as the?
You mean not-for-profit insurance companies?
Not-for-profit insurance companies, yes.
No, it does not. The IRS 990 Schedule H is only for hospitals right now, but anything that's not-for-profit, universities, others, I think everything's on the table in the future as it relates to that, because the government is hungry. And a hungry government is not necessarily a good thing. One last question? Yes.
Some of us are cursed with kind of long memories, and we remember the PHOs and IDNs of 20 or 25 years ago and the predictions that were made then that we would be going to a small number of large health systems. And I mean, ACOs aren't quite the same thing, but they're close. And why do you think we're seeing predictions of that happening again? What's different now from what happened before or didn't happen?
All I can tell you, why is it different today than it was 20 years ago in those predictions? All I would say is it takes a long time. It takes a long time for people to agree to give up their control. Whether it's communities, look at the physician numbers that I showed earlier. Physician independence, for example, takes a long time. I think everyone was thinking perhaps the money was going to drive that more than anything else, and I don't think that was the case. I think it was more than, there's a lot more at stake, a lot more driving this than money. Not much more, but there's a lot of other factors like control, community control. If your community hospital says it's going to be sold to another company out of your community, man, that's a gut-wrenching time period for that community. It's a very difficult decision to make, and sometimes that's what results in the CEO getting let go, and then we're going to try this all over again. Another 5 years, you're in the same situation you were 5 years earlier. It just takes time. Finally, the community goes, oh, you mean we can't really afford to have our own hospital? Oh, well, you didn't tell me that. You know, so it just takes a lot more time than anybody thought, I think. But now, when you look at the numbers, we're definitely moving in that direction quickly. Thank you all very much. Appreciate your time.
Thank you, Paul. That was fantastic. We really appreciate that. And I know there's a lot more questions. So please give Paul a call, and I've got his information is there. And we really do thank you for coming all the way from Washington to give us the good insight. We appreciate it. Thanks. Okay, what I'd like to do is to ask, we have just a quick announcement, and I'd like to ask two of my colleagues, Edith Dees and Bernie Lynch, to come up here and do this presentation.
Thank you, Chris. Please join us. We want to take a few minutes right now to acknowledge our generous sponsors and express our appreciation. So in alphabetical order, I'm going to invite, are you coming up, Buddy, or Steve? Who? You've been nominated? Buddy from DSS, thank you so much for your sponsorship. And I'm going to give you 2 minutes to tell us who you are and a little bit about DSS.
Well, thank you very much, and we're certainly a proud sponsor of both CPAHIMSS and PAeHI. And Distributed System Services was formed back in 1995 by Jim Sweeney, who was a retiree from IBM, and his goal in establishing the company was to provide regional technology services to a very large customer base. Today we have over 400 customers. We have a Tier 3 data center in Reading, Pennsylvania, and we host a lot of EMRs, as well as in higher ed, we host a lot of the educational applications. We do PC services, 7x24 help desk, and just about any type of technology at the infrastructure level. We're also building out our healthcare solutions, which you can see more of that if you go out to our table. And we're looking forward to getting more involved in the healthcare and continuing our sponsorship of these two fine organizations. Thank you.
And next we want to thank EMC, Crystal or Dana, who?
Kevin's here.
Kevin, who's nominated? Excellent. Thank you.
Very much. So again, I'm very excited. Kevin McKittrick from EMC. We do a lot of sponsorships with HIMSS on a national level. This is our first time for participation here. So it's great to see the common themes that we hear. Again, I applaud you for all your efforts on what you're doing with the focus that's put to reduce costs, if not to maintain them, and then everything you're faced with meaningful use and ICD-10 and health information exchanges, it's a lot. So for EMC, what we really do is we work with hospitals. About 50% of the hospitals leverage EMC for their information infrastructure. So we understand that data growth that you're seeing, I don't know how many times data was mentioned today in the discussions. We're really at a tipping point where it's going from physician-led to now data-fed. So really what we're trying to do is work with our customers to manage the information you have, get the value out of that information, leverage analytics to securely access that information, get it where it needs to be. So this was a great event. Thank you very much. Yes, thanks.
Thank you. And next I'd like to thank either Bill or Kelly from Information Builders. Oh, thank you. Bill.
Good afternoon, everybody. Bill Catraba with Information Builders. We're real pleased to be here today. So we help healthcare organizations really manage a lot of the information and data that we've been talking about today, from clinical applications, financial application, operational applications, kind of pull all that information together, and then really people use it in their really daily lives, whether it's on an iPad, in a dashboard, a scorecard, sometimes predictive technologies. And that ranges from folks like Lehigh Valley, where we're doing a large project, to community hospitals like Butler, which is up north of Pittsburgh. So certainly glad to be part of the day here today. I think it's a real exciting time in terms of HIT and pulling all this information together, and we'd love to help any of you folks with that as well.
Thank you so much. For those tokens. Good gifts.
Thank you.
Oh, whoa, Bill, one more. Thank you.
Oh, one thing, Bernie.
Oh, no, I just wanted to mention also that there is a happy hour post this conference across the street that is being sponsored by IBI. So it starts at 4:15, and everyone is welcome to attend. Thank you.
Thank you. Why don't we do this? We've had a really great session. Let's take 5 minutes because we've got another set of fantastic speakers coming up. And go ahead, and there will be, if you want to put your boxes back in the area, if you need to move it out, and then we'll be back here, of course, just to take a break. 5 minutes.